Okay, everyone, welcome. Happy Saturday. Thank you all for joining here. For those of you that are here live, a big welcome and thank you for joining me live. There will be a Q&A at the end. So if you have questions, I'm happy to talk to you personally one-on-one and answer any questions you have about Prism and practice. For those of you that are in Canada, Australia, Europe, the UK, wherever you are, welcome. I know that lots of people join me from all over the world, Latin America, even some parts of Asia. So they'll be watching this on a recording, and I always feel like you're here with us. So I welcome you as well. So today, we're here to talk about PRISM, which PRISM stands for Pain Recovery and Integrative Systems Model. This has been a 3-year labor of love, really, amongst me and some other health professionals that I'll introduce you to in a little while. Physical therapists and pain researchers and health and wellness researchers that really looked and said, hey, we need a new model for treating chronic pain. And we specifically need one for our kind of very broad and deep depth of scope of practice that we now have in physical therapy. So I'll be talking about PRISM. It's really the world's first whole health approach to treating chronic pain that really gives practitioners personalized treatment options and a process really for helping people and guiding them through pain recovery. So these 3 circles are probably not foreign to you, right? When you ask people what's the cause of pain right now amongst pain researchers and pain clinicians, they'll say, well, there's no real one cause of pain. It's biopsychosocial, right? So the biopsychosocial model has been around since 1977. The American Physical Therapy Association probably adopted that model. Actually, probably a little bit late, probably somewhere in about 2007. And this has kind of been the main model that we lean on to both understand and approach the care and management of both acute, but specifically chronic pain. Now, with that model, you've seen these circles in many different forms and fashions, right? People take those circles and they start to fill them in with all the things that are in the biological aspects, the psychological aspects, and the social aspects. And depending on, which model you're looking at, people fill those circles with different things, right? So sometimes they put in things like genetics and physiology. Other times they put in things like thoughts and beliefs. All those things are part of the biopsychosocial model. However, there's been a lot of kind of criticism, I would say, with the biopsychosocial model. It's been around for a long time. The main criticism of the biopsychosocial model is that it tends to be somewhat reductionistic. And what I mean by reductionistic is that it tends to say, okay, well, for the psychological challenges, you need to see a mental health provider. For the biomedical challenges, you need to see either a physician or a physical therapist. Everyone and no one is kind of working in the sociology realm, so to speak. But really the greatest challenge with this is that it silos patient care. So it's inefficient and ineffective care because patients would have to move around our healthcare system, which can be very difficult, especially in the United States of America, and piece together a care team, which is not always easy. And oftentimes people have different, or therapists, I should say, health professionals have different levels of knowledge and expertise, even within a pain management model. That model originated outside the physical therapy profession. So if you're a physical therapist, this may not fit really well into what you're currently doing, or we've had a hard time, I would say, fitting it in. A lot of times it's because we don't have enough knowledge, skills, training, and resources, either in school or in the places we work, to really approach pain from a true biopsychosocial perspective. Now, I've starred the 2 at the bottom, and this oftentimes is not spoken about and sometimes can be shocking, but the model has never been operationalized for pain management. What that means is no one took the biopsychosocial model, because the biopsychosocial model was originally for just general health. And then people said, well, this applies to pain too. But no one ever took that model and said, here are the most important components when working for people with chronic pain. And that's a lot what you'll learn about today is our team looked at, okay, here is how you can start to operationalize this model and use it really for guiding your clinical decision-making as a licensed healthcare provider. And then finally, the National Institutes of Health, Federal Pain Research Strategy, as well as the American Physical Therapy Association and other associations had called and have called for new models of pain management. So in many ways, we were meeting that call to action. Now, since 1977, when that biopsychosocial model came about, we as physical therapists and other health professionals as well have improved their understanding and their scope of practice with regard to understanding how movement and physical impairments impact pain, understanding specific pain mechanisms, how pain education can help someone overcome pain. We now have psychologically informed practice, which is a big part of Prism and what we do in psychologically informed physical therapy. We're looking at ways we can positively impact people's mental health or help them flourish with good mental health. And then last but not least is looking at integrative lifestyle factors, things that all of us do every day, like feed ourselves, sleep, and manage our stress and avoid risky substances, and how that has an impact on the trajectory of pain recovery. So really what I'm saying is, as physical therapists specifically, we have really broadened our approach and our scope of practice when it comes to treating chronic pain. We're no longer looked upon as allied health providers, but we are now entry point and primary providers of pain management. So you see physical therapists now that have, practices in towns where people come to them first for pain, and we're also being embedded within primary care models in and throughout the healthcare system. The American Physical Therapy Association, through the Academy of Orthopedic Physical Therapy, did release a pain education manual in 2021. That pain education manual is a good start. We're happy it's there. It does lack in certain areas, and I think Prism would be a really nice addition to it to bolster really a behavioral approach to pain science and pain education. The reason why that is because as professionals, we really understand that pain, the whole pain experience, has a biomedical aspect of it. But we also have to consider psychosocial, contextual, behavioral, and the epigenetic lifestyle factors that we spoke about. Now, there's something key there on the bottom. And I oftentimes ask this when I present to sessions live. And I say, raise your hand and let me know if you think, as a licensed health professional, if you're really good at finding the source of pain or nociception. And you may want to do that right now. Like if you're in the chat thread, raise your hand and say, yep, I'm excellent at finding the exact source of pain and nociception. And the truth is, we're not. None of us are very good at finding the source of pain and nociception, because from an evolutionary perspective, just think of what the ramifications of that would really mean if we could really kind of identify the source and turn pain on and off. That wouldn't be very good, because pain is an essential survival mechanism, right? And so is nociception with that. With that, we learn that prior life experiences, learning, and knowledge has a big impact on pain and how pain impacts well-being. So it's kind of like where we are as physical therapists overall. But really, our team came together and said, we should not throw the biopsychosocial model out at all. We should keep that, but we need to evolve it in a way that helps clinicians inform their clinical decision making and help guide their clients and patients through a process of behavior change and recovery. So we asked ourselves, what should a new or improved model of pain management include? And if you're on the webinar today, just make sure that you are muted. Just make sure you're muted on your side. You're not unmuting yourself. Thank you. So we consider these things. So pain care is often siloed, and with that siloing, it's costly. We oftentimes, through the medical model, approach pain from a very reductionistic or pathogenic model. We sometimes approach pain as psychopathology, like people are depressed and they're anxious. And if they weren't depressed and anxious, then their pain would go away. We know that that's not true and that's not valid. Pain and psychopathology are two completely different things. Um, Today, we've had a big focus on risk factors, right? Identifying the indicators that put people at risk for pain. We have a number of risk factors. I'll talk about them in a little while, but just merely targeting those risk factors alone doesn't necessarily lead to the type of recovery we're looking for. Pain care is often single intervention based. So just exercise, just mindfulness, just whatever it is. We know that single interventions have minimal outcomes on pain management. That research has been done. And the best research shows that we should be doing multimodal or creating multimodal interventions. And then finally, we need whole person approaches that look at people as unique individuals. So with that, we put together a perspective paper that was published and validated in the Journal of Physical Therapy, or Physical Therapy and Rehabilitation Journal, in late 2023. And the title of that paper is called Prism, Pain Recovery and Integrated Systems Model, a process-based cognitive behavioral approach for physical therapy, although we realize that this model has really a good place for other health professionals as well, whether you're an OT or a health coach or a physician. Everyone really could use Prism in one form or another. Now, when you create a new model, you need to have a theory that supports it, right? An evidence-based theory. So I, of course, read a ton of the physical therapy theories that we have out there, all useful. A ton of psychology theories we have out there are all useful. But I came upon a bit of an older theory developed by a sociologist, a medical sociologist, actually, whose name is Aaron Antonovsky. He's no longer with us. But he really started to look at, instead of looking at what's wrong with someone, their pathology, maladaption, disease, let's look at what are the factors that help people maintain health and wellness, even in the face of chronic health conditions, so to speak. And Aaron Antonovsky created a rather well-known model, which is used quite frequently in Europe, which is called salutogenesis. And saluto comes from the root salus, meaning health, and genesis comes from the Greek meaning origin. So what are the origins, or how can we create health, basically? And salutogenesis has this kind of core concept, which is called sense of coherence. And when you're able to help people access and build a sense of coherence, it helps them improve their health and well-being, even in the face of some things that are rather devastating for people. What's really interesting about his work is that he started out looking at women who had survived Nazi concentration camps and looked at how certain groups of women were able to thrive psychologically, emotionally, physically, and even spiritually, even after going through this rather traumatic experience, if you will. And really what he has developed is a model for human flourishing, which is really what we all want, right? Of course, we want to decrease people's pain. We want to impact their pain in positive ways, but we want to help them flourish in all the various domains of their life. If I could wrap up salutogenesis in kind of one slide, it would be this. All of us are on a continuum. You're either moving toward the right on this continuum toward vitality, health, and wellness, or you're moving toward the left toward a continuum of sickness, illness, and disease, or a total absence of health. So he wasn't very concerned with diagnosing. That wasn't really his thing. He was like, diagnosing only really goes so far. Even if you have the best diagnosticians, which a lot of us as physical therapists are, how do we move people toward health and wellness, right? So now that we know what's wrong, how do we move them toward health and wellness? And that key principle of sense of coherence really spoke to me as a pain management physical therapist, because one, That construct is multidimensional and it has three key parts to it. One is comprehensibility, which means does the person have the ability to understand their condition, what's happening with them, what the cause of their condition is. Two, do they have the resources available to them, both the internal as well as external resources to manage their condition? And finally, can they extract something meaningful from the experience or something meaningful from the condition? So when you look at this, so sense of coherence is kind of here in the center. This is a construct that you can measure and track. And as you add in these resources, these biopsychosocial resources, it shifts someone's sense of coherence to the right. It moves them toward health and pain recovery. When people lack these resources, and I'm going to go through what these are in a little while, it moves them more toward pain persistence. This is what keeps pain persisting in someone's life, is they lack certain resources or they have deficits in certain areas. Big evidence-based slide here, lots of data on here. Basically, what this really shows you in a nutshell is that the factors that we're interested in pain management, things like pain catastrophizing, fear of movement, someone's ability to cope, self-efficacy, quality of life, flourishing with good mental health, reducing comorbid non-communicable diseases. All of that has been shown with salutogenic approaches to pain. They've shown that in people with osteoarthritis. They've shown that in people with chronic low back pain. They've shown that in people who are out of work due to chronic pain. So basically, we have the evidence to show that salutogenesis can be applied as an evidence-informed way to help people overcome chronic pain. Now, with that, there are two key mediators or the mechanisms of change that are happening with these more health and wellness or salutogenic approaches. The first is resilience. So helping people access resources that make them or help them be resilient to pain. The more resources they have, the more resilient they are to pain. Second is when you skill people with these resources, it helps them move along a trajectory of positive growth. So this comes from the trauma literature, right? So post-traumatic growth, positive growth is a very similar construct. When you look at clinical studies, anywhere between 10 and 50% of individuals report moderate to high growth after a life-challenging event if they have access to skills that build resilience. And what you'll see in your patients and clients is their personal relationships start to improve. They notice new possibilities in their life. They appreciate life differently. They have a greater sense of personal strength. And even if you're in the spiritual realm, they have an access, or they can access, like I have the spiritual sense that this happened for a reason and something actually good came out of this, rather what I thought was a negative experience. There are various trajectories of resilience that you can see. So there are three that I kind of want to point you towards. So if I can bring your attention to the left-hand side here. So this is function. So you're moving along this trajectory with good function in life, so to speak. And then boom, pain and or disability happens. If you already have the resources, you're able to sustain good function, right, throughout your life course. Second one down, moving along life of good function, pain and disability happens, and it causes your function to decrease for a period of time until you're tooled with those resources. And then you bounce back. And again, you're back on that life trajectory of resilience. Bouncing back happens in various forms. In the first case I have here, you bounce back, or someone bounced back, let's say relatively quickly. In the second or the third case down here, the trajectory is a little bit longer, but eventually someone does bounce back as well. Now, for some people, the fourth one down here, you'll see that there's only a partial recovery of function, right? So some people may only exhibit partial recovery of their function. And then there's this last one down the bottom, which I think is really interesting, which you see happen with many people with chronic pain and or trauma, is pain or disability impact them in a negative way. They lose some of their function. They access those skills for resilience and growth. They return to where they previously were. And then something really interesting starts to happen. They start to exhibit further growth of function above and beyond where they were when they started. So you may see one of these happen. You may see all of these happen. All of this in itself can be a trajectory where you bounce back. You may only have partial growth, then you bounce back fully, then eventually you access a greater sense of growth. Now, what the research shows, and this is what I think is really exciting and oftentimes new to practitioners, and this makes so much sense from a physical therapy perspective, that yes, people have vulnerability factors, things like fear, things like anxiety, things like avoidance, things like symptoms of depression, right? Pain catastrophizing is probably the biggest construct, the one that we're able to kind of point our finger on the most, right? So they have these vulnerability factors. But what actually holds more weight with regard to helping someone bounce back is not targeting the vulnerability factors, but helping someone access a sense of resilience through changes of process like acceptance, self-efficacy, pain literacy, embodiment, improving their physical capacity, improving their metabolic flexibility, improving their psychological flexibility. And with all that, what we really do is we impact gene expression, or what's known as epigenetics, right? We have an ability to impact all of that. So we shouldn't ignore these vulnerability factors. They're there, and we should take them into consideration. But what holds weight with regard to that trajectory of recovery is more the resilience factors, and the research is pretty clear around that. So there's a summary of kind of where we are. Latest research tells us that focusing on resilience can lead to a transformative change in vulnerability. So when you apply Prism, you're helping someone build resilience. That resilience leads to growth. Whoops, sorry, let me go back. Resilience leads to growth. As you experience growth, you become even more resilient. These two are kind of feeding off each other, if you will, or impacting each other in a positive way. And that's what leads to pain recovery, all wrapped up in a more resilience-based health promotion approach to supporting people through that recovery of pain. There's also something else happening in Prism, and it's also happening in all of our literature, and that's that learning or neuroplasticity, right? The change that we're hoping we seek in patients and clients is a process. It is not a one-time event. It's not a one-time intervention, right? So what you're doing with people in pain recovery is you're taking them through a process of change. That process is therapeutic, so they're gaining something therapeutic from it. That process is dynamic, meaning it's not top down, it's not bottom up. It's really happening in all ways at all times. It's progressive and it's multi-system oriented toward behavior change. There are lots of change processes. No one has really kind of evaluated them in a systematic way. We did that with Prism. And a good model really goes beyond risk factor or vulnerability identification to encompass resilience factors, because the resilience factors are the factors associated with better outcomes. Process-based models are relatively new. You can start to do this tomorrow or today if you'd like. The way you start to adopt a process-based approach is you develop a partnership with your patient instead of sitting in the expert role. You ask yourself, what are the processes of change that I should target here? And how can we address them? And reframe the question, what treatments work, to how do or how does a specific treatment work? Consider processes that improve motivation, cognition, affect behavior, attention, and self-regulation instead of focusing just on those single interventions. consider things that are obviously physiological and sociocultural. Make sure you take a multi-system approach. So we talk about the nervous system. It's not the only system that's impacted. There are lots of systems in the body that are impacted, i.e. the musculoskeletal system, the digestive system, as well as the systems that we're embedded in, right? The social-cultural systems. And approach pain from a strength-based place, focusing on wins and positives rather than what's wrong. This is what's wrong, the pathology, the impairment or negative-based model. Okay, so let's take a deep dive and let's look at Prism. It has both domains and processes to consider. What was really important to all of us is that we created not only a model, but really a clinical decision support system. So Prism is a clinical decision support system that takes into consideration all 4 parts of the clinical decision-making process. So it's evidence-informed. It identifies patient context as a key domain. It addresses specific behavior change processes, and it considers patient preference for integrative care. So if you want to know what the 4 parts of clinical decision-making in pain recovery should be, they're here on the screen for you, and that's what's included in Prism. How do we do this? A big-time literature review of randomized controlled trials, systematic reviews, and meta-analyses that looked at theories, mediators and moderators of change, mostly along the level 1 and 2 evidence. We use the impact guidelines for assessing trials in pain management. And we looked at pain models published in the physical therapy literature between 2016 and 2022, kind of the most up-to-date models, if you will. What's considered in Prism is that it is a multi-systems neuroscience approach for physical therapy education and practice. It's integrative, it's ludogenic, it's whole health. Obviously, we're looking at a whole health approach here. It's process-based because it's process-based. We're taking into consideration the process of behavior change. It's trauma-informed and cognitive behavioral. It is a strength-based model that focuses on resilience and growth. And then finally, it's obviously functionally oriented. So we want to improve function. That may include complete symptom reduction, like symptom of pain completely goes away, or symptoms of fear or kinesiophobia go away. But ultimately, we want to engage people in a process that empowers them to achieve wellness and participation in life, community, whatever it is that they want to re-engage in. That really is the most important part of everything that we do. Okay, so here is the step-by-step process with Prism. I call them the 6 Ps of pain recovery. They are person context, purpose, pain literacy, pain mindset, physical capacity, and physiology. So instead of bio, psycho, and social, right, these are the domains where you do the work, so to speak. This is not the process itself. And this is not the intervention itself. These are the places where we need to work with our patients as a team in a collaborative way to improve certain important areas or domains of life. So I'll give you a minute to look at those. So again, instead of biopsychosocial, you have these 6 important domains where you know where to work or where the work needs to be done with someone. Now, each of those domains have behavior change processes, right? Because we're trying to impact or affect some kind of change within each of these domains. When we initially created this model, we had 5 processes under each domain. And then we said, that's too big. Let's really narrow this down to the 3 most important behavioral change processes that you see. So I mentioned before that Prism is integrative, right? So you'll see all these different processes make it an integrative approach. It's a whole person or salutogenic approach, right? So you'll see aspects of whole person care here. Taking person context into consideration, that's the most important part when you start with anyone. What are the individual factors that they have? Do they have people and processes that support them in their life? And is there anything happening in their life socially on a big level that could prevent pain recovery? health and wellness, right? So we look at things like optimizing nutrition, improving sleep, circadian cycle, improving physical activity, right? The big health and wellness realm here. It is a trauma-informed approach. So safety learning is the key process that comes right out of the trauma psychology literature. So Prism is a trauma-informed approach. Beliefs. So it's definitely, you see aspects of pain education in here, but really beliefs is the most important process to work on when you're looking at improving someone's pain literacy. Psychologically informed physical therapy, this whole column here under pain mindset really looks at psychologically informed care, right? How do we motivate someone for the change that's needed? How do we make sure that someone's mindset is flexible? And how do we help them progressively change their behavior, activate behaviors that move people forward? And then finally, purpose. Can someone access meaning and values in their life? And when that happens, we help them reconnect to an identity that they lost, develop a brand new identity that creates positive change, and we give them a sense of autonomy where eventually they don't need us and they can move through life in a healthy way. You're welcome to take a screenshot of that right now if you'd like. I'll kind of pause so you can kind of take all that in, take a screenshot and store it. Let's walk through a quick case study. So if you're on my email list, I started talking about this case study. This is a patient who came to me a number of months ago, 30-year-old male, chronic low back pain. He had 4 years of on and off traditional impairment-based physical therapy. So primarily lumbar flexibility exercises, lumbar stabilization, manual therapy. It did help him, but it really only took him so far. Somewhere in that process, he's a pretty intelligent guy, very well educated, online, reading lots of books, listening to podcasts, reading lots of things. He heard that certain types of personalities, if you will, are the cause of chronic pain, specifically perfectionistic type personalities. And he said to himself, well, I'm kind of a perfectionist, and my dad really pushed me hard in life to succeed. So let me go seek psychotherapy, so to speak. And he had 8 months of psychotherapy once a week. And at the end of the 8 months, he was like, I'm doing psychotherapy and I'm doing traditional physical therapy, and I don't see anything changing. Essentially, I'm stuck, right? So he was actually referred to me by his physical therapist, who said, hey, I know this other physical therapist that takes this really different approach. You're kind of plateaued with your progress. I know you're having difficulty still coping in your life. Let's try this different approach and see what happens. And when he came to me, he said, I've been reading a lot. I really want to return to running. I think I can do that, but I know I need some mind body skills to help kind of bolster my recovery. So that's really what he said. Like, I want a mind body approach, if you will, which essentially a mind body approach is Prism. It's a psychologically informed approach. All right, so let's look at pre-treatment first. So the focus of Prism is on resilience. So I use 2 things in the evaluation that are really key. These are free tools that you can use as well. The first is the pain resilience scale. It's only 14 questions, and it measures how resilient someone is to pain. So this is a pain-specific measure of resilience. Scored from 0 to 56. Higher levels of pain resilience indicate higher pain resilience. The second is the OSPOR yellow flag, common in the physical therapy literature. It allows you with just 7 questions to measure both resilience factors and vulnerability factors. So you can see the positive yellow flags that he had were low levels of pain resilience, meaning low pain self-efficacy, low self-efficacy for rehab, and low pain self-acceptance. And he had high vulnerability of fear avoidance, kinesiophobia, pain catastrophizing depression, and pain-related anxiety. So yellow flags here. Pain interference, simply measured, this is a validated evidence pain interference intake questionnaire, which looks at pain intensity. Obviously, higher scores means more severity. So he had 5 out of 10 pain. His activity was severely limited, sleep was limited, mood was impacted, and stress was impacted. And then I use what's called the global impression of change. So this is a validated measure that asks a patient or a client, do you think this intervention had a positive outcome? Did you notice a change in your health and well-being? Scored from 0 to 5, no, there was no improvement. To 5, it very much improved after care. So this is pre-treatment. Okay, so what did I do? Just 8 sessions. Session 1 always involves the processes that are related to patient context. Individual factors, peer collective, and social determinants of health always have to be taken into consideration at the initial evaluation and at that first treatment session. Now, as you move down from session 1 to session 8, you'll see either single processes. So this session, I just focused on beliefs related to pain. Session 3 and 4 was just on resolving those few impairments that he had. Then you see in sessions 5 through 8, I combined processes that align well to each other, that are interconnected and reinforce certain behaviors. So to return to being physically active, it takes a lot of psychological flexibility. To become more embodied, to understand the mind-body connection, if you will. You have to be able to start to feel safe in your mind, safe in your body, and safe navigating through all the various environments that person was kind of navigating their life. So you see the last 3 sessions, a big embodiment and safety learning, trauma-informed approach. Now, if this was a different person, I may have used different processes. I may have changed the order. It's really dependent on the person and what they're scoring based on the initial evaluation, the initial assessment. And I've developed a Prism specific assessment to support the entire model, which really guides care. All right, so here's the post-treatment. So the post-treatment is in green. So his pain resilience increased from a 24 out of 56 to a 36 out of 56. So a significant improvement there. On the OSPRO yellow flag, he had these yellow flags for pain resilience. After treatment, those yellow flags were absent. So that's a statistically significant improvement in pain resilience. So he had no more yellow flags that indicate he had lower resilience. Yellow flags were absent for vulnerability. So his vulnerability scores were absent as well. So basically, any yellow flag that was present before care was now absent. They all improved. All the psychosocial factors related to distress improved. Pain went from a 5 out of 10 to a 1 out of 10. Everything in the activity, sleep, and mood realm significantly improved. The only thing that was left over was a little bit of stress, which, you know, to me, numbers like 1, that kind of fluctuates to me. These are almost like 0, if you will. And he reported, based on the patient global impression of change, that he was very much improved after the 8 sessions. Many of you know that I have other products and programs out there. One is the Pain Innovator Program, where clinicians are coming to me and saying, hey, I want to do unique and innovative things in my practice. There are many professionals in that program specifically that are using Prism or using aspects of the Prism model in their practice. This is Dr. Reed Hickman, who has a really amazing physical therapy practice in Burien, Washington, called Pain Science Physical Therapy. And really the model underscores everything that they do in their practice, from the initial engagement on the patient phone call, all the way through, obviously, the evaluation, the treatment, and the discharge and follow-up that they use with their patients at Pain Science Physical Therapy. I want to bring in a colleague of mine as well, who helped me develop Prism, who's here today. So I'm just going to find Rose. Rose, you want to, I'll find you and unmute yourself and you can share your screen.
Hey, Joe. Good morning, everybody. I don't know that I need to share my screen necessarily, Joe, but first of all, I want to say thank you to you and to everybody who's attending this morning, just for the opportunity, and also to be able to get feedback from clinicians that are also on the same page in terms of holistically addressing patients' pain experiences. There's been a little back dialogue in the chat. Alex, you raised a really important point about patients' priorities. And so that's just an example of the types of feedback we get. And when we are having the opportunity to speak with our colleagues, first of all, I want to say that the Prism model, like Orit had mentioned, it's really transformed not only my clinical practice, but most of my time right now is spent in teaching at a DPT program. And so our students are learning this approach. So it's transformed my clinical practice, but it's also transformed the way that we're educating our students to help them prepare for contemporary clinical practice in a way that makes sense, that builds on what we've learned in the past and allows us to move forward in the future. And it's also transformed my research. I do a lot of research on resilience, and one of the things that I've discovered in past research or evidence on working with people who may have more permanent disabilities, not only chronic pain, but things like spinal cord injuries, Parkinson's disease. The literature there shows that we would expect that people that are more disabled would have lower satisfaction with life. And what we found actually is that satisfaction with life and the severity of somebody's disability are not necessarily directly correlated, meaning that you can be severely disabled and still have a very high satisfaction with life. And so what I like about Prism is that it is very asset-based. It looks at what the patient's assets are in terms of salutogenesis, and also has that focus on resilience, where even if the physical impairments are permanent, that does not mean that the patient is still not capable, or the individual is still not capable of growth and moving forward. And the other thing I really like about it in terms of direct patient management is that it's got this collaborative approach that really appeals to me. But also, people that experience chronic pain often wind up in this adversarial relationship with their body. This is especially true. We see this a lot in people that have autoimmune diseases, where basically their body is attacking itself. And so that adversarial relationship happens when people are trying to distance themselves from their body, because they see their body as a source of discomfort and suffering. And the Prism approach really helps address that adversarial relationship with the body, which then forms the motivation for the person and empowerment to take better care of yourself. The embodiment, the coming home to your body and really experiencing yourself and your spirit, your soul, however, I don't want to get too fringy, but how that fits with the body in terms of who you are in as part of the whole person, matches the Prism model really well. That embodiment, that coming home to the body, also facilitates an internal locus of control, because now I may not have control over my pain, but I have control over the behaviors that influence the way that pain either causes restrictions or facilitates my engagement in what matters most to me as an individual. And so by getting a better idea of what the patient's priorities are and their role perceptions, that allows us and the patient to uncover their motivation for getting back to function and living well with pain, even though the pain itself may not necessarily be changing. So we're tapping into that person's sense of life purpose and how they can regain that sense of purpose, even if their physical restrictions remain behind. And so those are the things that I've taken away from this Prism model. And I hope that colleagues also take away from this model as we are collaborating with patients to come to a sense of what matters most to that person. And in terms of what matters most, what changes in behavior or what interventions might be the most valuable in terms of matching those goals.
Thank you, Rose. So I think in just that, just a couple of minutes, people can see how amazing Rose is and why she was so key to developing this model. I mean, what Rose just said right there is like a whole webinar worth of information in and of itself. Rose has she has a DPT, and then she has a PhD in health behavior change. So really at the forefront of looking at health behavior change in physical therapy and all the ways that we use it. both in pain and for other conditions. I think it's so Rose is teaching this at the university that she works at, Emily and Henry, which is in Virginia. I'll be teaching at two different universities in the summer in the DPT program. And I know, I think all the co-authors on the paper, Stephen George, Carrie Rothschild, Jan Besner, I forgot to mention, all of them have already implemented into their DPT program. So, what's nice about a validated system that is published in PTJ is that the evidence is there to support it. Okay, let me just go back here. Thank you so much, Rose. If you have any questions for Rose, please put them in the chat thread. I know she's in there communicating with you all. You may know that Rose teaches a course on MI for the Institute as well, so you might want to check that out. I'm always pushing people toward the amazing work that Rose is doing. All right, so let's return to webinar here. Just a couple of key points that I would like to point out kind of as we start to wrap up, and I want to go to the Q&A and give you all a chance to ask questions. So Prism is obviously a new model for pain management that builds resilience and nurtures positive human growth. We're looking at people through a new or different lens. So not seeing people as broken or damaged, but seeing them with the ability to thrive, even if pain persists on some small level. Physical therapists and other providers can use Prism to manage the multidimensional nature of pain. That's really important. We're moving away from unimodal, moving toward multimodal interventions. It's a strength-based approach. I think that fits so well with what we do as physical therapists. The first thing you would do as a PT is you're going to evaluate them for their strength, right? So people have an idea that we're making their bodies physically stronger, right? Well, the whole Prism model is an approach to make someone physically stronger, psychologically, emotionally, and even spiritually stronger if you're okay talking in those terms. There are evidence-based levels of behavior change processes in there. And finally, Prism has use for individual practice or individual sessions. Group, I've used this in group sessions already. In person, telehealth, my entire practice is telehealth, and pretty much all I do is Prism. It has technology applications. I'm starting to work and think about technology applications. Of course, it has, as a model, has uses for physical rehabilitation. It really does have good use in mental health as well, or helping promote good mental health, if you will. And for those out there looking at education, pain science and pain education, if you need a model for teaching this in DPT or other health education programs, it's a good model for that. So we're going to go to Q&A. It's been a while, and I'm excited, really excited today, not only because this is 3 years in the making, but it's been a while since I offered a new training to my community. And obviously Prism is something new. I'd like to do something a little bit different for all of you. And what I'd like to offer you today is actually a live training with me. So it'll be a live online training. The training is called Prism in Practice, Transforming Pain Management. And in this training, you'll learn the real world application of this new validated evidence-informed model to comprehensively assess and treat chronic pain. So here's the course information. I'm giving you a couple of weeks to prepare, basically. You can link to the course. I have it in the chat thread. So you can copy that link or click on that link and go to the course page. But I'm going to walk you through all of this now. So it's a live online training that I'm delivering. It's February 3rd and 4th, which is a Saturday and a Sunday. We'll start at 9 Eastern and we're going to end at 5 Eastern. I know that people from all different time zones and other countries take our trainings. I have taken that into consideration. So if you're unable to attend part of the training or maybe even all of the training, I will upload a recording so you can access it in perpetuity after the training, if you will. Of course, I would love if you're there in person, right? You get to train and train with me, meet me. And the big part of this is I want to connect all of you to each other and learn what all of you are doing in this space as well. And it's approved for 14 CEUs for physical therapists and physical therapist assistants. So here's the 10,000 foot view of the training. So you'll learn this new validated system to treat pain. You'll be able to uncover the origins of someone's pain. Notice I said origins because it's not just one cause of pain. Pain is multidimensional. We'll go through quick, easy ways to comprehensively evaluate pain. I realize that some of you work in practice settings where you're very busy and have less time, and some of you work in practice settings where you have more time. I'll show you brief ways to evaluate pain comprehensively, as well as more comprehensive ways to evaluate pain that fits into anyone's clinical practice. Of course, very technique driven, so you'll learn techniques that you can use in the clinical setting. That specifically includes the behavior change processes that you see in Prism and how you can apply those for well-being. How to build resilience through this strength-based approach. And then finally, which is really important, is how do you get paid and how can we work on reimbursement, right? So best practices and strategies for payment and reimbursement. If you want a daily agenda, so day one, we're going to go through the core concepts of Prism. We're going to go through how to comprehensively assess the full complexity of pain using Prism. We're going to spend some time on the therapeutic relationship. So as I developed Prism, I also developed a specific approach or therapeutic approach, if you will, of working with a patient that's very different than how you've been trained as a physical therapist. There will be cases. So there'll be a case day one that we'll work off of. And with that case, I'll show you how you can apply the domains and the processes of Prism. Day two, another case presentation. We'll go further into how to apply those domains and processes. We'll look at how to apply Prism in clinical practice, whether you're working in a hospital, whether you're working in a private practice, whether you're working in a multidisciplinary practice, whether you're working in your own practice. Again, payment and reimbursement strategies. I'm going to give you some networking opportunities. I think it's really important that once you're done with the training, you not only stay connected and network with me, but you also network with other physical therapists and other health professionals. So I want to build a community here of people who are using this new model. And of course, there'll be resources, handouts, and materials that are all part of the training that'll be delivered at the day of the training, as well as in the portal that you can go back to and download whenever you need to. So it's a new training, Prism Transforming Practice, 14 CEUs. You'll go through a multi-system neurosystems based approach to treating pain. It has real-world application, heavy on behavior change. So all of you are behavior change experts. This will turbocharge your ability to help people change their behavior. Of course, evaluate pain. You'll have the resources for your patients. You'll have the resource for billing and reimbursement. And the costs or the investment is $695. Again, live training with me in a couple of weeks, February 3rd and 4th from 9 to 5. If you can't be there, if you're in another country, that's fine, or a different time zone. If you show up a little bit late, that's fine. It'll be recorded, but would really love to see you there in person. And I know you'll show up in person.